I'm Dr. Ezra Amsterdam, Professor of Internal Medicine and Associate Chief for Academic Affairs of the Division of Cardiovascular Medicine at the University of California, Davis School of Medicine and Medical Center. It has been a real pleasure to be at a truly outstanding meeting here at the International Academy of Cardiology World Congress on Heart Disease. My topic for the HJC Swan Memorial Lecture was cardiovascular disease, focusing actually on coronary heart disease in women, a fresh perspective. I dealt with a number of very important areas that have been evaluated and investigated in the last 20 years to improve our knowledge on women. A major issue is, of course, we all recognize that cardiovascular disease is the leading cause of mortality in women. However, I did point out that cancer is actually the leading cause of mortality in women until the age of 75. After 75, the toll of cardiovascular disease is so great that averaged over the lifetime, it definitely is the major cause of mortality. So I wanted to clarify that. The other points I wanted to make include the fact that despite what I think may be in some areas undue focus on differences in the sexes with regard to heart disease, the risk factors for heart disease are actually the same in men and women. Age is very important, and the disease has its onslaught, as I just said, its major onslaught in women at older middle age and older age. Of course, younger women, premenopausal women, do have heart attack and other cardiovascular diseases, but the mortality overall at this stage of a woman's life is secondary to cancer. A concern I have is the use of imaging, stress imaging, to assess the possibility of heart disease in women who present with chest pain. I feel that this is really a violation, in a sense, of repeated guidelines that in both women and men who have a normal baseline ECG and are able to exercise, the plain exercise treadmill should be the initial screening test or the initial test to evaluate these individuals for underlying cardiovascular disease. This is not practiced in most centers. In fact, many boast about the fact that they never do stress testing without imaging in women. And they train new cardiologists in that manner who go out to spread this inappropriate word. This is something that really needs to be challenged and corrected. The very interesting topic that the WISE study, Women's Ischemia Syndrome Evaluation Study, has evaluated is the possibility of microvascular angina as an etiology for vascular events, cardiovascular events, in women who have non-obstructive coronary artery disease, or actually normal coronary arteries. There is some data to support this, but differentiating it as specific to women is not yet really founded because of the lack of comparative data in men. So we really don't know the extent to which this may be a foundation of so-called Syndrome X, and we don't know if it does occur in women, how it compares to its prevalence in men. So there are many similarities in the etiology, the evaluation, and the assessment and identification and management of cardiovascular disease in men and women. But there are differences, but in my view, the similarities far outweigh the differences. A final word, and perhaps the most important comment that I could make, is to underline the fact that that knowledge of cardiovascular disease in women has led to a tremendous improvement in our identification and treatment of women with coronary disease when the disease strikes, as I said, in generally older, middle-aged, and older women. This has led to improved management and a sharp reduction in the mortality of cardiovascular disease in women, period. Finally, we still need to continue to exert our efforts to reduce the leading cause of mortality in both women and men over the lifetime to reduce this toll of death.